Thanga Prabhu. You are seeing me on CXO TV.
All right, so now we can start with the session and I'll be on mute.
Okay, I'm taking over. So, Namaskar. Welcome, Dr. Thanga.
Namaskar, Professor Suptan.
Fine. Okay, so Namaskar. Yeah, welcome, Dr. Thanga Prabhu. It's a real pleasure having you for the chat. Yeah. So, first, talk briefly about your background and your hobbies and what would you like to share with us over the next hour. Over to you, Thanga.
So thank you very much, both of you, for asking me to talk on this subject. My background is I'm a medical doctor, I'm BBS doctor. I'm an emergency physician, intensivist by training. After working for almost a decade in Abu Dhabi in clinical medicine, I made the switch to medical informatics. I trained and qualified from UK. I did my master's in health informatics from Swansea University in UK. And after that, I worked with the NHS for a while and then joined G Healthcare in Bangalore. I was the clinical director for 10 years. We did tele ICU and digitizing the operation theaters in Fortis Escorts Heart Institute in Delhi. Then I worked in with the Reliance Foundation on a doctors, stroke nurses, clinical training module using patient avatars called iHuman. Currently, I work with Cohere Med in Bangalore, which is a company working on doing big data analytics in healthcare to detect sepsis and arrhythmia in intensive care units and in the general community patients. So this has been my career. I do still practice medicine. I'm in touch with patients and that part we are primarily doctors. But I look at technology as an enabler to do many things that so then hope you can hear me. Hello. So then I can't hear you. Atreyi, can you unmute?
Yes, sir.
Yeah. So Suptan, I think your network is going in and out.
Okay, let's.
Yeah.
Okay, you can continue. So I'll come to the next question. Yeah. So I think over the years we have been hearing the terms medical informatics, health informatics, clinical informatics. Now it's become digital health. So how would you really vision of this medical informatics to digital health?
Yeah, that's a very interesting question. So the thing is, names will change, terminologies will change, but effectively what we are trying to do here is use the advancements in technology, which is happening at a very rapid pace. And this field itself, the medical informatics field itself, is not very new actually. It's about 50 years old. Right from the days of the early days of computerization, after the office space was computerized, then it went into banking, retail, travel, hotel industry, airline industry, and healthcare industry also. But what we have seen is healthcare industry inherently is a very high, has got a very high safety margin. And for various reasons, which, in the informatics community, we try to understand, and it's an ongoing area of research, the adoption rates have not been as high as it has been in the other industries, simply because it's a very high safety environment, and failure is not an option at all. Having said that, so it was computerization, and earlier we used to use these client server architecture machines. Then we went on the cloud. Today we are talking about software as a service, infrastructure as a service, platform as a service. And then the latest, of course, is the API calls. So you don't have to worry about interoperability, and using API calls, we are able to interconnect multiple systems, and and get the information flowing. And then, of course, from the computer, we moved on to the mobile and the tablet interface. And mobile has become very big, ubiquitous now. So the mobile operating system and the mobile platform allows almost everybody to have access to technology. And if you go back, say about 30, 40 years, only academic institutions where mainframes were installed, only specific people had to take permission and go in and then, access the systems. Unlike that, it has become, available on everybody's hand, and we are all using mobile phone platforms to do this. So the field of informatics has been evolving. Only the names have changed, but for people like me and Professor Sukten, who have been in this field for a decade and more, we find that the actual working of the industry has not changed. So we are struggling with the same problems. Maybe we have sorted out a few, but we are also getting opportunities to sort out many of the other things, which we will talk about as we go. And yes, digital health is an apt term to use. So medical informatics is defined as an interface between computer science, information technology, and the healthcare domain. So this intersection is medical informatics, and we tend to sort of stick to that area. And we, being clinicians, we tend to stick to the clinical informatics part. So which means if somebody in the dental field is using it, is called as dental informatics. You have public health informatics, you have health informatics, you have nursing informatics. So depending on which specialty they are using, they call it, but broadly it can all come under health informatics. And digital health is, of course, a much bigger space, within which I would say health informatics fits in. And we are very proud that we are health informatics. And within health informatics, I consider myself as a clinical informatics person. So I work with doctors primarily and nurses, and try to make their workflows more efficient, and see if we can actually transform the bigger healthcare space by working with these people, who are, of course, the key players in the healthcare space.
I think George Bernard Shaw had said that, science is always wrong. It never solves a problem without creating 10 more. So how do you think this health informatics or digital health is actually helping the end users? And when we say end users, at one end we have the patients, the other end we have the healthcare providers. Is it helping both?
Yes, that is the right approach. Unlike what has happened so far, we have seen. I was part of the. I was actually studying, and I was in UK when the national program for IT was getting rolled out under Tony Blair for 10 years, and they spent close to 9-10 billion pounds. Similarly, the US ended up spending a lot of money, almost 10 billion US dollars. This is all huge amounts of money which was spent, and so we can argue on whether it was a success or a failure. But having been there, having seen that, I can tell you that yes, there were a lot of failures, but there are a lot of positives which came out of it also, which is given us the platform to sort of build on top of as we go forward. So every user has got a different perspective to this technology, and definitely this should be helpful to every user in the healthcare space. So broadly, if you look at it, who is the most important person who should benefit from this technology? I believe it should be the patient. A patient who comes to the healthcare system is either in pain or he has a problem which needs to get sorted out. So how much ever we can do to make that experience smoother, easier, and comfortable is what is the number one focus. So the patient has to be the main focus. Then we come to the what we call as providers in the American healthcare space. These are the people who actually provide the care. So these are the doctors, the nurses, the pharmacists, the lab technicians, physiotherapists, the administrators, and a whole lot of people who enable the care process within a hospital. Each one is important, and each one has got a different workflow and different requirement. We have to ensure that each of them gets to use technology optimally so that his or her work is made easier. Then you come to the payers. The payers are the people who fund the system. So these are either academic institutions, medical colleges, the insurance industry. In many countries, including India, 70% and above are actually paying out of the pocket. So the patients pay out of pocket. So that segment, if you look at the government, of course, is the biggest payer, when it comes to healthcare. So the government, the insurance industry, and the other payers are always looking at, what is the spending, and clear metrics are required to measure, what is the spending, and it's a business in the end. So it has to, be tracked, and both top line and bottom line has to be taken care of. So quarter on quarter and year on year, there has to be growth, because that's the nature of business. And only when you have growth, you will have enough funds to invest and further grow the organization. So that is the payers part of it. And regulatory agencies, they have a oversight, and the government takes care of public health in most of the places. So the government uses these metrics for their own, public health purposes. Classic example is of corona now, which we are handling. Unless we know the size of the problem, we will not be able to manage it. So like that, tuberculosis, HIV, and leprosy, and then the most important non-communicable diseases, and then the maternal child health problems, and all these things that the government takes care. All of these have, metrics which can be captured and used to optimally deliver the solutions to these people. So each of them, if you take the private sector, has got a different take on this, and if you take the public sector, they have a different take on this. But definitely everybody looks at, the data which is available and which is used for further optimizing and making the system more efficient.
I think there's a lot of we talk about EMR or EHR, electronic medical records, electronic health records, and then now the new term is the PHR, personal health records. Then there's also specialty AMR. So would you like to just clear some confusion regarding these?
Yeah. No, there is no confusion when it comes to people like us who are, informatics people. The confusion is when, the 5-10 of us who are actually working in this space started, talking outside. And when the telemedicine practice guidelines were rolled out, suddenly everybody woke up. And with Corona coming in, even the guys who were, saying that over my dead body, I'm not going to use any technology. Now suddenly they are asking, can you tell me, some good systems that I can use? Because it is not an option anymore. They have to use it. So when this has happened, then these terms have become, very important. So electronic medical record is nothing but, as the name says, electronic capture of the medical record. So in a normal OPD, in outpatient department or in an inpatient department, when we see patients, we jot down on the case sheet on the paper, on pen and paper, we record what we are observing. So there is a structured way of doing it. And when I say we, I'm saying as doctors. So we have history and physical examination, and then our provisional diagnosis, and then the initial treatment, the management plan, and then going forward we have the progress notes, and this is to keep track of what we have seen from day one of seeing the patient, and that helps us with fine tuning the treatment as we go along. Similarly, every clinical specialty has got its own notes. So there is a nursing notes, which is very important, especially in critical care areas like the emergency and the operation theaters and the ICUs, and in the wards, and the pharmacist and the physiotherapist. So every clinician has got his own records. So an electronic medical record is an electronic version of all these records in the healthcare environment for one encounter. So when within one organization, so if I go to hospital A and I go there for a consultation and they maintain a record of mine, and that becomes an electronic medical record. An electronic health record is what I would have if I go to say 3 hospitals. I go to hospital A for a dental problem. I go to hospital B for a hypertension problem, and I have been to hospital C because I'm suspecting I'm having corona. So now I have 3 different hospitals, and the sad part is these 3 hospitals don't share records amongst them. So far, the capability was not there. So each of them will have a paper-based record, and it will all be in separate folders when you do it on paper. But when you have it electronic, when you have it digital, their capability is there to actually share the records across. So if we have an electronic health record, then I have my electronic health records, which will consist of electronic medical records from hospital A, hospital B, hospital C, and so on and so forth. So I like to frame it in a mathematical way by saying EHR is equal to EMR1 plus EMR2 plus EMR3 and so on and so forth up to EMRN. So this would be an EHR. Now coming to PHR, this is a very new concept, a personal health record, because now, as I said, the patient is the main person in this ecosystem, and the patient now has access to his records. So the PHR is a personal health record. Now that comes in 2 forms. Either the personal health record is just an access into the electronic medical record, electronic health record that is held in the hospitals. So if I log in using a username password, I will be able to pull records from different hospitals and have a complete record of my details which the hospital is maintaining, which is what we as clinicians would be comfortable using, because the clinical people are maintaining that record. There is another subset where for chronic diseases especially, we let the patient actually record his details and share that with the providers. So now with a lot of mobile apps which have come up, chronic diseases are monitored using these mobile apps, and the wearables and the patches which are available. So if a patient has a cardiac condition and we want to monitor him for a month, he can wear a patch, and that record will continuously keep getting updated. So for corona, we know that the oxygen levels are very important, and there are devices which can be worn continuously by the patient. The moment the oxygen level goes down or his respiratory rate goes up, which could be an indication of things not going well, this would come from the patient side. So a patient health record is a patient owned or patient accessed health record, which gives a oversight of what is his health conditions. And the problem is, as an emergency physician, if a patient comes and says, doc, these are my health records and this is what I am maintaining, I can tell you that I will not be very comfortable using that data, because it's a given that it's all in English. But if you try to read through it, as doctors, we look for specific information. So there is a little bit of problem in that. But going forward, I think, there is a business opportunity where companies are helping patients in keeping that medical record accurate, so that at the point of requirement, it is available. Now, having said that, I can tell you that a patient, as a doctor, I see the patient once, in my consultation. And probably, if it's in the emergency, I don't have a review for the patients. Chronic disease patients would come to the OPD. So the interactions with the healthcare provider is much less. So I would say I would see 50 patients in a consultation. Okay? But for the patient, his problem is a very personal thing, right? So for a patient who has gout, for a patient who has, I'm saying gout because it's quite a rare condition and not much is known about it. So people, tend to suffer silently without knowing, how to manage it. And allopathy strangely has only painkillers and a few drugs which will reduce the uric acid of the patient, when uric acid levels has no correlation to the severity of the condition. As an example, I'm telling. So you could take any condition. So the patient actually lives with a problem all his life. So if you ask me, there is an inherent, imbalance between the amount of data that the patient has got about his condition as compared to the doctor. So the patient would be the best person to own the data. Of course they will need help, and that is where opportunity is there for companies to help the patient in maintaining that data in a clinically robust way, so that that can be used by a healthcare provider at any point in time, either in an emergency or during travel, or in a regular healthcare encounter when they actually end up meeting a doctor. So patient health record is again a new concept, but this is the difference. So EMR, electronic medical record, is just an electronic version of the medical record. EHR is the electronic health record, which is the overall health record of the patient, and as we say, it is from birth to death, so it should be the entire lifetime's health record. And the PHR is another version of the electronic health record, but owned and maintained by the patient. That's the basic difference in the three of them.
In fact, we have the National Digital Health Blueprint, which was released last year. As a fallout of that, we now have the National Digital Health Mission, where this and sharing of the health information is very, I think, interoperability and standards. So would you like to shed some light on that part?
Yeah, so the interoperability part that we are talking about, luckily we are, learning from other countries who have tried to do this. And me and Professor Supten have been part of, a lot of this activity ever since 2008 onwards. So then, at that point in time, we were given a mandate by the Ministry of Health. So we are all volunteers in a digital health work that we do for Government of India. And it was called IHIND, Indian Health Information Network Development, and we all worked very closely on that. So we learned from the work that has been done in different countries, and as you know, the US is quite advanced in using technology. So globally, if you see, very few countries have managed to deploy technology, the information technology, and get healthcare together, digital health. And so the learning was that there are a lot of systems, electronic medical records, and hospitals and healthcare providers inherently don't have a reason to share the records with others. Like between hospitals, they have the fear of competition, because in the end it's a competitive business space. And if the records are available to the patient, then the patient could go from hospital A to hospital B, or from provider A to provider B. So these are all various reasons, and also the legacy system. So the electronic medical records that were put in place earlier, didn't have the capability to communicate with each other. So as I said initially, it was all in silos, and these systems have been deployed. Now, moving from one EMR vendor to another EMR vendor can be very, very difficult and very expensive. And definitely, if they have been using a system which is not capable of communicating, to suddenly, make it communicate and, make it interoperable is very difficult. So different ways and means are being tried to get it going. I'm talking about the advanced, economies, and I'm talking about the advanced countries like the USA, UK, and many countries in Europe, Australia, New Zealand. So they have their own set of problems. Luckily, in India, like we have done with the telecom, we have started a little bit late, and this may be a blessing, because we have learned from all these other systems and realized that we have a good opportunity now to do it once and do it right. So in IHIND, when the Health Information Network was conceived in 2008, what we proposed was to look at India as 600 districts and create an environment at every district, so that the data can come together at the state headquarters level, and from the state headquarters level, it could come together at the national level. This was 2008, when client server was very popular. When the cloud came in, the same thing was, proposed as it should be using a cloud infrastructure. So the National Digital Health Mission, which has been launched, is a very welcome move. definitely government has the power and the authority to push, and wherever we have seen healthcare, IT, and digital health going forward, it has to be either with regulation or with a very strong business case. And the first regulation is what takes it forward. So the government has taken the lead, and Professor Suptan himself was the director of the National Health Portal, which was the one of the main things for them to start off. So the National Health Portal is very much, thanks to the brilliant work he did when he was there for 6 years, is very much available. It's a neutral portal where you can get healthcare information in a non-biased, non-commercial way from the government of India. Then the health information network started rolling, and this tends to be the more complicated, more complex way of doing it. So there are components to it, and what has happened is we have the digital locker, which is like a government owned and operated facility where I could have my electronic health record. So I can put my electronic health record into the digital locker, and it would be accessible to me wherever I am with the username password. Me as a patient, I'm saying, as a citizen of the country. The National Digital Health Blueprint, with a lot of input from the Ministry of IT, Ministry of Electronics, and Ministry of Health and Family Welfare, and a lot of other, including the Law Ministry, everybody has gotten together, and CDAC Pune is the National Resource Center. So the strength of the government of India is behind this, and they put this together. And then we have the senior IAS officers leading the National Health Mission. So it's run on a mission mode to digitize the healthcare ecosystem completely in the country. And based on how Aadhaar was deployed, and the success of Aadhaar led to the Unified Payment Interface, UPI. So we are all able to use the Unified Payment Interface now for making payments seamlessly, effortlessly. So the usage of credit cards has actually come down by a huge margin because of the UPI interface which was put together. The same team, people who actually worked on this, are working on the National Health Stack, which is conceived to be of a similar nature. So the National Health Stack would have patient data with all the patient data privacy and everything taken care. So they call it privacy by design. So even while capturing itself, it would be, take care of the privacy part, which is very important when it comes to healthcare. And the patient data would be anonymized and de-identified and available for further public health research and for so many other secondary use cases which will come up. And I can share that so what is publicly available. So if we go to a hospital or a healthcare system, and what are the things we get? What are the things that are publicly available? You get a discharge summary if you come out of the hospital. You get your labs, the lab tests and the results which are available, and then you get your prescription which is available. So these are all pretty much in the in the public space. So these are the three things that are going to become available. And that is a whole lot of information for pharma companies, because they need this kind of information to further come out with new ways of treating diseases and come out with new drugs, and for the further progress in pharma. Insurance is so far lagging. We don't have health insurance in a big way, but these kind of data would actually help them to come out with very innovative and good insurance plans. Arogyasri, which started off in Andhra, and now it has been taken over by multiple states, and now the government of India also has taken it over as the Ayushman Bharat, is a health insurance model which gives access to almost everybody to healthcare, and that's the model which has come up. So the National Digital Health Blueprint, it actually gives you a blueprint of how the digital health should be rolled out with a lot of guidance and guidelines. The National Health Mission, on a mission mode, they are running it and they are getting it up. So as we go forward, it's very encouraging to see that we are going to be one of the countries who is actually doing things in the right way. And what that means is, we will have digital health records. Our Prime Minister announced it on the 15th of August, and so we are going to see that becoming a reality, that we will all be having electronic versions of our medical records. which is going to be very useful for patients who are having chronic conditions, and for patients when they are moving around. So irrespective of where you are, you'll always have your records with you. And to an emergency physician, this is like superb. Otherwise, if I get a patient whose identity I don't know, I don't know what all allergies he has got. Does he have a sulfa allergy? Does he have a penicillin allergy? Can I put this fellow into a MRI scan? Does this fellow have any metal implants inside him? So many unknowns are there, and we manage it because we don't have a way to find out those things. But those things are going to be taken care of, and a whole lot of good things are envisaged when the actual national health stack goes live, which we are eagerly looking forward to. One last point is the national health stack, just like how the UPI interface is allowing, will have open APIs. So it allows a whole lot of startups to come up with innovative ideas and come out with a lot of attractive things, right from the patient experience on registration to advanced things like keeping a patient compliant to oncology drugs and to the non-communicable diseases drugs and infectious diseases, especially the drugs have to be taken at the right time for the right duration. Tuberculosis was for 18 months to 12 months. These are long non-compliance issues are there. So for handling all this, this is going to be enabler. So that's the best part. I mean, you have data, abundance of data, and this data is only going to increase over time. And this is the world of big data analytics. And I can tell you that I've been working with a company who has used this kind of big data analytics, and we are in a stage where the disease is evolving. This virus is new. There was nothing like this earlier. The virus is new. How it is actually harming the human body, what is the pathology, what all organs it is affecting. Humanly, it is impossible for us to react to this using the old model where we had about 50, 100 years to study a disease and then come up. Now it is just in time. The virus is new, the disease is new, the management is new, and what they have done is they've used big data analytics to actually read through about 100, 150 million biomedical documents using natural language processing and find patterns in it using artificial intelligence and figure out that this virus is not just affecting the lungs, it's also affecting the kidneys, it's affecting the heart, it causes blood clots. So much of learning is happening just in time. So this is digital health. I mean, properly deployed, taking care of the patient data privacy, which is the PDP bill, which is going to come up. We are set to, actually transform healthcare and make Ayushman Bharat successful. So Ayushman Bharat works on prevention. 80 to 90% diseases we know can be prevented. So that is the health and wellness centers which will do the prevention. Only those who actually need secondary or tertiary or quaternary care will get referred, and they will come up to the next level to, get the care that would be required. So, and all this is hinging on the National Health Mission and the digital health platform, which will enable this to become successful.
Yeah, I think you have touched upon a lot of issues together. So I think one of the important things which you probably didn't mention specifically, but I'd like to say there's a sandbox available for the National Digital Health Mission. So those who are developing APIs, they can test. COVID-19 pandemic, this has been called as a big, real digital disruption. I mean, we talk about it, digital disruption, but this has really happened. And this SARS-CoV-2, the novel coronavirus, is actually being called as the biggest CTO, the Chief Transformation Officer, which has really digitalized a lot of things. So how do you think digital health is leveraging the efforts of the CTO of COVID-19?
No, very true, very true. See, inherently as human beings, we have a lot of inertia. We don't tend to do change. Change is actually, something we resist naturally. So if you go through the change acceleration process training in G Healthcare, where I work, they tell you that, resistance to change is normal and to be expected. So if you find that, there is no resistance, there's something wrong, either they are already, given up on it and they're not going to be doing what you're telling them, or there are some serious problems which, fit into some of these categories. Like, it could be a technical thing, it could be a political thing, or it could be an attitude problem. Some people just don't want to change. So we need some kind of a kick, some kind of a push think alternatively. So when Corona hit us in, I think it started in November of last year itself, and slowly it was, growing. And in Bangalore, we had our first case, which I think was the first one to be recognized when the guy from the US came back, and that was sometime in the end of Jan and early February. After it came, it has been like a continuous challenge to the healthcare environment. What it has done is it has actually put a spotlight, which is what IT does. The moment you introduce information technology into a system, it is like switching on a floodlight. So what I tell is, if any organization is trying to implement information technology, you have to get all your processes in place. You have to clean up the system, okay? Because once it is on, then everything, all the good, bad, ugly, everything is, visible. And that's not a very pleasant sight if, the inherent organization is not in a strong form. So Corona, after it came in, this made, it has changed everything. So like we are doing this, otherwise we would be sitting in some conference in some 5-star hotel in Delhi or in Bombay or some place and having a conference. But look at this, I'm in Bangalore, people are in Delhi and, in different places, and we are connecting and we are doing this. I've been talking like this to people in the US, in Europe, in UK, in Australia. So we are all connecting and we are working. So the capabilities of technology which were available to us, we were not using it that much. Corona has ensured we are using it. We are all working from home. So the networks, are very robust, and we are logging in and we are working. I like your idea of calling it a chief transformation officer. Yes, exactly. That's what it has done. Telemedicine, which is another component, which was, it's related to health informatics in a way that it is the technology part, was not very successfully adopted across the world, because the option was always there for people to travel, and it was just lagging. Just imagine, the Medical Council of India, just before they were replaced by the National Medical Commission, the Board of Governors did a quick job, and then they got all these wrinkles ironed out, being the regulatory body. So the telemedicine practice guidelines were released. And what was hitherto, in a gray area, we didn't know if, we were on the legally right side, whether we'll get into any problem if you actually practice medicine using telemedicine. And there were some 1 or 2 instances which actually put a break to that. But clearly, when the telemedicine practice guidelines were released by the government of India, that's a strong stamp of approval. And now hospitals, because of Corona, they have lost a huge amount of revenue opportunity, and all of them are bleeding. But the telemedicine opportunity which came up, they are all offering the telemedicine consultations, and that has become very normal. Going forward, I think that is going to carry on. And similarly, like I said, the big data analytics capability, which allowed us to learn, and it is allowing us to learn more and more about this disease. So this, what we learn in Corona, we are applying the same thing in oncology, in cardiac diseases, in HIV/AIDS, and so many other things, because we have reached a point where humanly it is not possible for any one person or a team of people to keep up with the amount of knowledge that is exploding globally. And being a global community now, if there is a new discovery in the US, or if there is a new discovery in Japan, we expect to use those technologies globally. We expect to use it everywhere, right? So how do we keep up with that? That is where technology comes in, and that is where, this natural language processing and automatic analysis. So when I first heard, I was shocked to hear, 100 million biomedical records, and these are lab reports, clinical case histories, genomic data, a huge lot of things, something similar to what Watson was doing, IBM Watson was doing. But technology has meant that you don't need a supercomputer like Watson to do it. Technology has meant that we can actually distill all this knowledge and make out, the sense from this data. And going forward, I can see that it has been a blessing in disguise, because we have started saying namaskar. There's no more handshaking. We have started washing our hands with soap and water. So yes, we are controlling Corona, but what else are we controlling? All the infectious diseases are getting controlled, we are wearing a mask, which means the amount of tuberculosis is going down. In the community, tuberculosis was there. It was not like, we didn't know who was having tuberculosis. Now, these are all indirect benefits that we are deriving it. Of course, it is bad that, we are hit by a pandemic and we have had so many deaths. But looking at the positive side to it, it has definitely made us, rethink our way of working, and thanks to Corona, digital health has got a very big push, and we are moving forward, because now people are asking us, how can I, transform my public health center? How can I, use digital technologies in my hospital? I have actually been approached by so many groups, because we have been working in the tele ICU space for a long time. Corona wards are inherently, virus heavy. So the viral load is very heavy. So that's why they have to wear the PPE kits and all that, with all the problems of doing that. So technology is very easily helping that. I recommended and advised the group was, have cameras inside the ward, have a team of, senior clinicians sitting outside. They don't have to go into the ward, and have, relatively young people to work inside the ward. And the connect is through a telemedicine. It's you can call it telemedicine, but the consultant is sitting outside and using a tablet to guide the clinicians who are inside, looking at the vitals and looking at the monitor. This is how we are actually using technology now, and then going forward, it is going to be very helpful to look at all the other problems also. So we are seeing a huge transformation happening, not just in India, but globally.
You have rightly pointed out the highlighted on this telehealth. Now, one of the parts of it is tele-home care. And there, I think the role of wearables, patches, Internet of Medical Things, and that comes in a big way from where you get a lot of data. So when you're talking about big data analytics, so it's not just from the lab values, but also from home. We are now getting access to that. And for that to really utilize, we do need health data literacy, which probably is an overlooked area. So would you like to combine these things? How do we really make people health data literate so that we can leverage whatever information is coming through the analytics into actionable insights, actionable information, informed policy making, and so on?
Yeah, that's a very important point, as you mentioned. The amount of wearables and patches is, increasing, thanks to the early work done by companies like Fitbit and the Apple Health Watch, which started monitoring for arrhythmias. We work regularly with a lot of companies, many of them based out of Bangalore, who are coming out with a patch. A patch is nothing but it's like a bigger band-aid, which a patient can just stick on his body, and it is able to capture temperature, pulse, respiration, BP indirectly, and SpO2, which is your oxygen level. These are the 5 parameters for those of you who may not know it, which are monitored in the intensive care unit continuously. So a patient who is in the intensive care unit can actually be monitored at home. So the thinking now is, don't bring the patients into the hospital if we can avoid it. Keep them at home, treat them, manage them at home as much as possible. If at all they come into the hospital, keep them for the least amount of time that they need to be here, manage them, send them home. So it is happening very much in India. In Bangalore, I know corporate hospitals who are discharging patients post surgery, post chemotherapy, post the acute phase of management, Corona also. And once they go home, they are given a set of devices which they have to wear, and that data through Wi-Fi goes into the cloud, accessible to their treating physicians and doctors and a team of people who are able to monitor this, and they are able to guide and manage the patient. So healthcare at home, yes, is the future, and this is going to be working with old age. As the population gets older and older, we are seeing that in India also our population is living beyond 70, 80, 90 years now. Old age homes, nursing homes, long-term care facilities, prisons, places where either moving the patient is difficult or getting a doctor to go in there is difficult. In all these places, telemedicine is helping, and telemedicine is enabled further by using these wearables and patches, because that gives you the extra points of contact. So you get more information about the patient. and that is for the immediate care that we are providing. And since it is digital, this data is available to us for further analysis. The COVID research that I told you that a company was doing uses all this data, and big data analytics, the machine learning part of it actually works on that model. So more data means, it becomes more and more accurate. The sensitivity and specificity of all these decisions that it arrives at goes up. So yes, definitely we are looking at a huge amount of data explosion going forward. But we are already there, because all the social media networks that we use, the Facebooks and the Instagram and WhatsApp and all these guys, they are using big data analytics, in a very big way. So healthcare is adopting it, and this is only going to be better for us going forward. So if you ask me in 5 or 10 years time, like how we wear a watch, we'll all probably be wearing some kind of a wearable. It could be something we stick on our chest, or wear it like a watch on our hand itself. And like the Star Trek tricorder, it would be able to actually get a lot of information about us and continuously track and keep us healthy.
I think you have brought into another important issue. I mean, we are getting easy access to a lot of data, which is personal. Health data is very personal, very private. What to do with that?
Okay, so the thing is, what I have seen, I've lived in the US, I've lived in UK, I've lived in the Western countries, I've lived in Abu Dhabi, I've lived in India also. I grew up in India, and I'm now living in India. Many things that we just blindly follow what the Western countries do is not really, to be applied directly when it comes to our culture. As an example, white is considered, as pure in our culture. Okay, where when there is a death, people actually wear a black color for the funeral, in these Western countries. Whereas in our country, people wear white. Okay, that much of difference is there. We are like 180 degrees. So when it comes to the way we approach problems and these things, so in the Western countries, they have their own reasons for why they protect the data that much. And in the US especially, they are very, very possessive. They don't want the government to know anything about them. As opposed to that, we blindly trust our government. Okay, when it came to Aadhaar, I don't think anybody objected to it. Right? It's a good, we inherently trust the government, and we know that it's a welfare state. It is doing good to us. We trust the government. When it comes to healthcare information, I find that patients actually want others to know that they are not well, because that is our social structure. If I am in the hospital, I want my friends, to call and tell me, don't worry, you'll be all right. That support structure is there. So I'm not saying we don't need patient data privacy, but what I'm saying is this is the nature of how we are, and how it is in India. But why should we protect this healthcare data? The simple answer is, when it is on paper, it can lie all around the place. You can walk into any hospital literally and pick up, any number of files you want. Nobody will even know that. Okay. But if I put together 1 million records of patients, okay, now that 1 million records can be a lot of value for somebody who is, able to use that data for various good or bad purposes. Good or bad purposes. Okay. Pharma industry can use that data. They can come out with a lot of new drugs, new ways of treating diseases, new ways of using the same medicine for multiple other diseases. So that helps them. Insurance industry, again, it helps them. The government, again, it helps them. It guides their treatment. The hospitals and, the general R&D that we do in healthcare, it helps us, because more data means we can, make our systems more accurate. What is the negative side to it? If you go in the dark net, which is, the place where, which is kept hidden from the law and order authorities, and, where all the illegal activities take place, where drugs and arms and these things are sold, stolen credit cards are also sold. So they say the value of healthcare data that is sold is at least 6 to 7 times more than, financial data. So this is for the Western countries. When they get the social security number and they can do insurance fraud, they can, create so many ways of making money on it. So all these illegal activities are also there. And so data needs to be protected. And we have gone through multiple iterations of this. There is no way that you will be able to completely de-identify a patient, because de-identify and you can re-identify that patient again. Technology allows you to do that. Okay, if you anonymize it, hopefully you will not be able to identify who the patient was. But even there, in advanced computer science work, they say that even if you anonymize the patient, I can figure out who the patient is from his age group, from certain characteristics. And with social media, it's almost impossible to anonymize anybody. So that means I agree with how the current team is saying data privacy by design. So the system itself is designed in such a way that the data privacy is taken care of, and we have gone through multiple directions. The Disha Act, which was supposed to come out, the Digital Information Security in Health Act, and so many iterations happened. The current one, which is the Private Data Privacy Act, which we are all hoping will come out. And this Professor Sutten, and I'm sure knows about this, is very much there. I think what I'm hearing is about 80-90% of the work is done, and once that is released, that is going to give us the blanket cover to protect the patient data, which will be the cover that we all are looking forward to. So yes, it is important, patient data privacy, and that would be taken care of by the Patient Data Privacy Act, not patient. Data Privacy Act, Personal Data Protection Act, Personal Data Protection Bill. Once it is released by the government of India, like how the telemedicine practice guidelines gave us the umbrella to practice telemedicine, that would take care of the patient personal data protection.
Yeah, so while the PDP bill is still in the parliament and it's likely to become an act very soon, but meanwhile, we have also come out, I think the government has released the health data management policy, which has been there in the public domain for comments. So that's also being used. So those are the areas where a lot of work is going on. And of course, multi-stakeholder consultations are on. But I'd come back to you for your personal experience. You have been working on tele-ICU and septicemia. So if you can just summarize in a way, I mean, how does this big data analytics lead to a better patient outcome? So if you can just sort of anecdotize your experience, I think that would be a great learning for the audience.
Yeah, I agree. And being the CXO crowd, I think it's very important that we need to sort of highlight this to the leaders, be it the CEO, CFO, CMO, the CMIO, this community, which is basically the leaders who are running the healthcare setup. So this, as I said, and I keep reiterating, patient, or going forward, it may not even be the patient. When we talk about wellness, it could be you and me, it could be the normal citizens of India, right? They are the nucleus of everything that we do. So every technology, every application, everything that we do should benefit that person. Okay, I'm not calling them a patient anymore, because going forward, I think the amount of people living with sickness is going to come down, and the amount of people that are without any illness, so that is the segment that is going to increase. The recent FICCI Heal conference that happened also emphasized, and they spoke a lot about it. So from illness to wellness, and from treatment to prevention. So technology allows us to actually predict, right? Predict so many conditions, and it's not a myth anymore. Conditions like diabetes and hypertension can be predicted, and following a healthy lifestyle, with careful adherence to the diet and exercise, and maintaining a good body mass index, you can actually prevent, many of these diseases. So this is the direction in which we are heading, and all the work that we are doing is clearly going to be supportive of that initiative. So to keep people healthy and not to fall sick in the first place, and if at all they fall sick, quick access to affordable, high quality healthcare is what is going to happen. And the patient, unfortunately, the patient doesn't have a voice, right? Everybody else, has a voice. Few organizations are there which are, trying to be the voice of the patient, but this patient community is a very fragmented population. So it is very episodic. The care that is currently happening is very episodic, and we as Indians are very, very bad at that. We will keep delaying it till the last moment. Even in Corona, patients come at the last moment to the hospital, and then, within 1 or 2 days they die. But if the care is initiated early, we all know that the outcomes are far, far superior, right? So that is what I would say. The patient is the only person we have to worry about, and keep so for people who are, working in startups and who are trying to come out with new ideas, how can we make the patient experience better? How can we empower the patient? Now, I told you, personal health record. This is a huge business opportunity, because patients will never be able to maintain, the personal health record in a way that their clinicians, leave alone the general practitioners. If you take specialties, if you take ophthalmology, if you take neurosurgery, if you take oncology, each of it can be so difficult to, understand and comprehend, that they need people to guide them, medically qualified people, clinically, with a lot of experience and knowledge on those fields, to keep the PHR in such a condition that it can be used by those clinicians. So the oncologist should feel comfortable in using that kind of data. Now, how do you ensure that? That is one business opportunity which can, come in. So patient empowerment and, making the patient actually able to own his health is what I think should be the direction in which we should be pushing. And that is very much possible now with all the apps and, the mobile interfaces that are available. I'm actually talking to some big organizations who are very much into this kind of work, especially with non-communicable diseases and oncology. We are trying to, bring awareness. So the first point is to bring awareness, right? And ensuring that people continue to maintain a healthy lifestyle and stay healthy and not get into sickness. And if at all they fall sick, so they, recover quickly, and then they make a quick recovery and come back. And also taking care of the elderly population that I said, which is, increasing day by day. They come up with a unique set of problems. And so that would be my one ask. Let us all think. We have been treating patients. So in the way we trained, I trained in Chennai. So we get the patient into the hospital. He has an abdominal pain. He has appendicitis. We operate him. We discharge him. We tell him come for suture removal after a week, and then that's it. I don't know what happened to that patient afterwards. So that is old way of practicing. What is the new way of practicing? I foresee, in 5 years I will have my own wellness clinic. I will give him, something to wear. And when he is wearing that, I will have access to all his data. So I won't have too many patients. I will pick up only 10 patients, and I will be able to monitor. I will be a health coach for my patient. Okay, a doctor becomes a health coach and guides his patient. And like what the WHO says, it has to be both physical, mental, and spiritual. Health is not just lack of disease. It is everything put together. So I think this government is also very hard working towards universal healthcare. I'm sure we are going to achieve it. And universal healthcare will mean accessibility to everybody. Healthcare, as WHO says, is not just absence of disease. It is also about, the all three components should be satisfied. And we, not just doctors, healthcare workers have a big part to play there, to be the coach for our patients and to handhold them and to keep them healthy and maintain the health of the population, which overall, if you see, education and health, when they go up, then the economy automatically goes up, because a healthy population is what keeps up the economy going.
I think this has really been a very, very informative session, and big thanks for that. So we have just about a minute or so. So before we part, I think what would be the take-home messages from your end?
Well, take-home messages are Corona was not a welcome thing, but it happened, and we in the East believe in karma. We believe that everything happens for a reason, and so many times we don't have a choice. That's what has happened. So instead of cribbing about it, we have taken the bull by the horns, as we say, and we have done a very good job actually. That is surprising. Unlike what happened in Italy and in Europe and in France. France, by the way, is under lockdown again, and in the US, where the president himself is now infected with corona. We have done a fantastic job for a 1.3 billion patient population with a pathetic primary healthcare setup. But for a few states, I can tell we can count in our fingers. Most of healthcare in India is pathetic. I mean, the infrastructure is lacking. This corona has put a spotlight on that, and it became very clear which are the states where the problem is very acute. Maharashtra is leading, unfortunately, with the corona problem, which just says that apart from Bombay, there is the rest of Maharashtra which also needs healthcare. So that has brought us to this point. And the government, we had government support earlier also, but the way things are being done on a mission mode has shown that things can deliver results. In Tamil Nadu, I've been part of many such activities, and every state has got a mission director, national health mission director, and now it is run at a country level. So all the little bit of things that needed to be sorted out, the policy, the infrastructure, the National Resource Center, which is CDAC Pune, with all the expertise they have. SNOMED City, when we spoke about interoperability, we sort of should have also spoken a little bit about it. So the basic three codes that are used: ICD, which is used for the term disease classification; SNOMED City, which is used for the clinical terminologies; and DICOM, which is used for imaging standards; and LOINC and RX norm. LOINC is a lab interchange standard, and RX norm is used for medicine. So these 5 standards, the government of India has made National Resource Center CDAC Pune as the I think we lost connectivity for a while. Am I audible now? Yeah. So what I was saying is government of India. What I was saying is government of India.
I think this National Digital Health Blueprint has also added HL7 to it. And NRCS has brought out this implementation guides for the India profiles as well. So I think.
So what I was saying is government of India has done more and is doing a lot more, because in the end they want to see that digital health is also transformed, like how they came up with national education policy to transform education, and so many other things. One by one they are transforming, and I have no doubt in my mind healthcare is transforming. It will transform, and we have to adapt to the new way of working and benefit from the many opportunities that are there. And this actually gives the National Digital Health Mission actually is a $200 billion opportunity, according to some of the Boston Consulting Group research that they have done, because it simply translates into new opportunities, de novo businesses, completely new ways of doing things. So we are looking at a very bright future where digital helps us achieve the many things that we wanted to do. And our CEO in Jeff Immelt used to always say, healthcare is a mess globally. If it gets sorted, this is in 2007, 2008, when one of our town hall meetings, he said, if it gets, sorted, if it gets transformed, it will happen in India. Simply because 70% and above people are paying out of pocket. And this paying out of pocket means I have a choice. If I don't like hospital A, I'll go to hospital B. If I don't like hospital B, it will go to hospital C. So Arogya Shri and Ayushman Bharat have done the same thing to the patient, given the choice to the patient. We need to empower the patient, give him access to his health record, handhold him, keep him healthy. That is what we as providers, as the healthcare, people need to do. And health informatics, we are there to do it. Digital health, the bigger community where we can include the telemedicine people and the other medical technology, the medical equipment, the patch makers, the device makers, and all of us are in this together. Let's change the world for good. And what we do in India, I think, is what the rest of the world is copying. Like how our Prime Minister said in the United Nations recently, we gave yoga to the world. Let's show the world, that healthcare also can be something which every citizen of the country can enjoy without spending a lot of money and taking them to below poverty lines, which sadly happens now. Most of the population, one health condition takes the whole family down, and suicides and these things are unfortunately common. We all this I'm sure will transform. So let's look at a very positive and bright future.
Thank you, Dr. Thanga Prabhu. Again,
Namaskar. Thank you for the excellent job, and look forward to having more such conversations.
Yeah. Atrey, now you can get the link to the recording and do, because we are going to do the next one also as well quickly. So I'm logging off. Atrey, over to you.
All right, sir. Thank you so much, Thanga sir. Thank you so much for giving us time. And you can share the link with me. I mean the recording with me. I'll WhatsApp you my email ID. You can send it to WeTransfer or any other thing. I mean you can also upload it on Google Drive and I can download it. Not a problem.
Yeah. No, don't WhatsApp it to me. I've shared my email ID. Just, reply to that email ID and I will share the recording from there. I'll put it on a Google Drive and give it to you.
All right. Okay. All right. Okay. Thank you so much, sir.
Thank you.
Thank you.